Vanakkam makkale, let's get started. Today we are going to see about myeloid neoplasm AML. Okay, myeloid neoplasm is broadly divided into three types: AML, myelodysplastic syndrome, and myeloproliferative syndrome. Today we are going to discuss about AML. According to Robbins, AML is a tumor of hematopoietic progenitor caused by acquired oncogenic mutation that impede differentiation, leading to accumulation of immature myeloid blasts in the marrow. So it's mainly the accumulation of immature myeloid blasts in the marrow. Okay, classification. It is broadly classified into four types according to WHO. According to WHO classification, is broadly divided into four types based on genetic aberrations and MDS like features, myeloid dysplastic syndrome like features, and therapy related and not otherwise specified. What are the genetic aberrations we see in AML? Very important one is T821. It's very important. Then we see inverse 16, that is also important. Then we see T15 17. Then along with this we see this RA PML fusion gene. Then we see T11Q23 V. Then that's it. Okay, so these are the common genetic aberrations we see in AML. Now we will discuss about pathogenesis. There are pathogenesis is discussed under four headings in Robbins. Okay, so mutation in mutation in AML tend to fall in four functional categories. Now we are going to discuss about all the four functional categories. First one is transcription factor mutation that interfere with normal myeloid differentiation. Okay, so here the normal myeloid differentiation is disturbed. First we'll discuss about this gene T821. It's a gene. It has a gene called RUNX1, and another gene is there, inverse 16. It carries a gene called CBFB gene. So both produce polypeptides. And they binds to these polypeptide binds together to form a fusion protein. It helps in normal hematopoiesis. It helps in normal hematopoiesis. This is what happened normally. But if there is mutation here if there is a mutation, and here is also a mutation, what it leads to? It leads to mutation in these two genes. So it leads to a polypeptide which is different, abnormal polypeptide. So these both abnormal polypeptide will get bind and form a protein. Fusion protein forms a fusion protein that blocks maturation of myeloid cells. Okay, this is one thing. Then there is another gene. There is another gene T1517. So what it will do? Like it carry PML and RA alpha gene in it. So here it's mutation. If there's a mutation in this gene, what happens? Its affinity for what will happen? It has its affinity For retinoid will diminish. For retinoid will decrease. Retinoids will decrease. Okay, so it leads to transcriptional repression. So it blocks differentiation of myeloid cells. So leads to pileup of proliferating myeloid progenitors. So it also results in AML. So what normally do? What normally happen means, normally RA gene binds with DNA and helps in differentiation of myeloid progenitors into neutrophils. So this is what normally happens. Okay, but if there is any mutation, it won't happen. For treatment, what we will do? For treatment, we'll give all trans retinoic acid and arsenic. Okay, so it will bind to PML and RA alpha gene and displace the displacement of repressor complex, leads to activation of transcription. So it clears the myeloid progenitor accumulation. This is what used for treatment of AML. So next I already said there are mainly four functional categories in which pathogenesis divide. First we have discussed. Now this is the second one. Second one is mutation of signaling protein that result in constitutive activation of pro-growth or survival pathway. Okay, here the signaling system is getting affected. Here we are going to discuss about FLT3. Here we are going to discuss about FLT3. It is a receptor for tyrosine kinase. It is a receptor for tyrosine kinase. What it will do? It will transmit signal. It transmit signal which mimics normal growth factor signaling, and it result in increased cellular proliferation and survival. Okay, this is how it supports AML. When a patient have both PML and PML RA mutation and FLT3, they develop strong leukemia. Okay, next what we are going to discuss is mutation of gene that regulate and maintain the epigenome. Okay, here we are going to discuss about enzymes called IDH1 and IDH2. When there is mutation, if there is any mutation, it result in production of oncometabolite 2 hydroxyglutarate. Okay, if there is mutation, it results in the production of oncometabolite 2 hydroxyglutarate. Then so for treatment, what we'll do? We will give IDH inhibitors for treatment purpose. Okay, then the last functional category in pathogenesis is mutation of TP53 or gene that regulate p53. What is TP53? It is a tumor suppressor gene, which it's a guardian angel. Tumor suppressor gene. It is a guardian angel which protect normal cell to convert into malignant cell. So if there is any mutation in TP53, it will result in tumor. Okay, these are the pathogenesis. Okay, next what we are going to discuss, morphological findings. First, very important finding is Auer rods. Auer rods. Okay, what are they? They are needle like azurophilic granules. They are positive of MPO stain. Positive MPO stain. So next finding is there is a bilobed nuclei. These two are very important finding. Here we can see it. These are the Auer rods. You can see, right, some needle like granules. These are MPO positive, myeloperoxidase stain positive, and they are mostly bilobed. Okay, they are bilobed nucleoli. Okay, these are very important morphological finding. And inside cytometry, positive thing is CD34 is positive and CD33 is also positive, and sometime CD15 is also positive. Okay, these are these are positive in AML. AML can occur after treatment with a topoisomerase 2 inhibitors. What it will do means it will cause mutation in KTM2A gene. So it can also result in AML. It is a very bad type of aberration. Usually it has bad prognosis. Okay, these are cytometry. Then what are the clinical features? This is very important to solve questions. Okay, actually what's the age? It actually occur after 60 years of age. After 60 years of age. So what are the clinical features we see? Anemia. They may lead to anemia, neutropenia. They may get anemia, neutropenia. Then thrombocytopenia. What are the clinical findings we see in this? In anemia, we see patient are fatigue, and in neutropenia, recurrent infections, and in thrombocytopenia, bleeding manifestations can be seen, bleeding spontaneously through mucous membrane. Mucosal and cutaneous bleeding can be seen, and very important thing, and it may also present dermatologically it can present as leukemia cutis. This is also a kind of manifestation in AML. Then infections are very common. Infections are very common. And what are the now we are going to discuss about prognosis, good and bad prognosis. Mutation. AML occurs due to T1517 gene aberration have good prognosis because we have treatment for that. We use all trans-retinoic acid and arsenic salt for treatment. Usually it have good prognosis. Okay, but for who have developed AML after 60 years, and with any other after developing after any MDS, it's MDS, they undergo treatment, and if they develop AML, then they will usually have bad prognosis. Okay, these are all about AML. It's very, very, very important. Just these are the important things you have to study. And thank you for watching. Thank you.